Good morning, everyone. The room is filling up. We're very happy to welcome you to this session, Beyond the Limits of osseointegration, maybe, or re-osseointegration. We're very happy to introduce very prestigious speakers, and I'm happy I'm moderating with you, Vivianne. It was a pleasure to prepare this session with you and with you too. And maybe you will introduce the first speaker.
Yeah, good morning, everybody, as well from my side. I think we have a really interesting topic this morning on a Saturday, 9 o'clock, and I appreciate that so many people are already here. And we have the privilege to have really the two rock stars in the treatment of peri-implantitis worldwide here this morning. So I would like to start with introducing then the first speaker. His name is Frank Schwarz. I think you already are very familiar with all his wonderful work. He's professor and chairman of the Department of Oral Surgery and Implantology at the Center of Dentistry and Oral Medicine in Frankfurt, Germany. He was awarded with 3 very prestigious prizes. He was awarded with the Andre Schroeder Prize, the Miller Research Prize, and the Jan Linde Award. So warm welcome to Frank Schwarz. And you will introduce the second speaker, Kajia.
Now, Vivianne, you made it really short to talk about Frank Schwarz. Now we have Hom-Lay, and I think this book doesn't have enough pages to show what you have done for the implant dentistry. You're a periodontist. I would summarize everything you do, being a teacher, an author, a researcher, and a clinician on an outstanding level, just like Frank Schwarz. And he's the director of the graduate program of periodontics at the University of Michigan. And I think he's one of the most publishing author in the field of implant dentistry. He's the immediate past president of the Academy of Osseointegration and the director of the board of the American Board of Periodontology. He's the chair of multiple committees, and he's co-editor or section editor of prestigious journals. And he's a recipient of many awards. Just to name a few of them, the American Academy of Periodontology awarded him several times as an Outstanding Educator Award, a Distinguished Scientist, a Master Clinician, a Distinguished Service Award, a Clinical Research Award. The American Association of Dental, Oral, and Craniofacial Research awarded him with the Irvin D. Mandel Distinguished Mentoring Award. And just recently, he received the Evidence-Based Dentistry Award of the American Dental Association. So we have 2 outstanding speakers, and I think we should start now with our topic, actually.
Yes, and since your opinion is really mattering for us, we would like to have your opinion first, and we would like to do a poll right now. So please take out your phones. We will present you 2 cases. I show you here the 2 cases on the slides. These are the cases you are going to vote. We would like to vote for those cases right after the 2 lectures in order to see if you have maybe changed your opinion. So let's start with the first case for the poll. Can I please have the first question, Josephine?
So when Hom-Lay and Frank gave us the cases, and Vivianne and I, we had a Zoom meeting and we talked about it. It's not so easy really to make the decision, when do I remove the implant or when do I start my peri-implantitis therapy? And I think I'm sure we will get some very clear answers on when to do what. And I think this is an important session for every one of us because peri-implantitis is a topic.
Yeah, and I think it's very important on Monday morning when you see these cases, you have an implant, you see separation, you see peri-implant bone loss, as in this 64-year-old woman, and then what do? I think these are really very relevant cases in the decision making, and I'm very glad that we will have after this session some very important tools which will tell you, yes, in this case we can treat and re-osseointegrate, or in this case we will remove the implant.
So please make the decision. Would you do an explantation? And we discussed it. Should we do one in this case or not? And you decided to do, almost 50% decided to do surgical reconstructive therapy. Okay, and another majority, explantation. Second case, what would you do in this case? Explantation. Will we have the same ratio? I'm wondering.
Yes, and I think here we are in the posterior sides. Probably there the concepts are a little bit different, and also probably the aesthetic demands from the patient as well. So probably, even though we have the same options, I'm wondering if the outcomes with the numbers from the audience will be different than before.
Yeah. If we have clear guidelines, I think it will make it easier to decide, okay, this is hopeless, or let's give it a try. And I wonder how successful some of the therapies are under certain conditions. So let's see what you choose to do in this case. Oh, okay. Let's see.
Also, 60% are for reconstructing the site. And we have 14% which would do an implantoplasty, and 2% which would go for an explantation. So I think we have interesting approaches to discuss. And I'm looking forward to the first presentation from Frank Schwarz, showing us the borders on the surgical therapy of peri-implantitis. Frank Schwarz, welcome to the stage.
Thank you.
Thank you.
It's not on? Now it's on. Yes. So good morning, everyone. It's a great pleasure being part of this session. So this is, of course, one of the most critical sessions that we will have in this conference. So we will deal with the management of peri-implantitis and, of course, to define the limits. So this is not my presentation, so we have to wait for 2 more seconds. So, yeah. So here we go. It's about the limits of a surgical treatment of peri-implantitis, and in particular, we will talk about reconstructive procedures, as most of you have voted for in the 2 cases that we have just seen. So the question is, where is the difference between the implant affected by peri-implantitis and the tooth affected by periodontitis? And of course, beyond many histopathological characteristics, one thing is uniquely different. And that's the fact, even if you have lost about 9 millimeters of bone supporting a 10 millimeter implant, the implant might still be stable, so non-movable, and that makes a huge difference. So I will target the question, where is the limit? To what extent of a peri-implant bone loss we still may consider a rationale to keep the implant in place? So before we start, I would like to refer to a very unique data source. So these are human histological studies that have been obtained after the implant removal at sites that revealed a massive and advanced bone loss. So these are exactly the cases that I'm referring to. So the 1 to 1.5 millimeter residual bone still keeping the implant in place. So the unique finding of this investigation was the fact that in the presence of an advanced bone loss, all the incoming forces obviously tend to increase the mineral density in the most apical area of the implant. That means the bone reinforces, we get a more cortical type of bone, and this is the explanation, or at least seems to be the explanation, why implants still function, even in the presence of just 1 or 1.5 millimeter of supporting bone. So keep this in mind. There is a certain adaptation to the process that we are discussing. So details make the difference. And this is something that is really important when you look at all these peri-implantitis-related defects. The detail is, in fact, in the defect. And here, just in a nutshell, these are the 4 most commonly used surgical procedures for the management of different types of defects. So the typical class 2 defect, it's the suprachestal defect, so mainly approached by the implantoplasty. The fully contained class 1 defect, the prototype defect for reconstructive procedures, but in this presentation I would like to focus more on protocols that were based on the fact that we have to deal with advanced critical defects, so the class 1 non-contained and the class 3 defect. So before we go into these surgical procedures, I would like to make one point very clear. And this is the definition of the treatment success. And here, of course, I would like to quote the most recent EFP consensus on the treatment of peri-implant diseases, so the S3 level clinical practice guideline. And it is apparent that the resolution of the inflammatory lesion measured by bleeding scores, suppuration, and the reduction of probing depth, these are clinical outcome measures. So re-osseointegration by no means is a clinical outcome measure. So this is something that we could never measure in humans or in our patients. So it's all about clinical assessments. And as you can see, clinical assessments should be performed at 6 months, and radiographs should be taken after 12 months or even longer periods of healing. So again, a radiographic defect fill, according to this definition, is not part of a successful treatment outcome. Of course, this is what we want to see, but if there is no radiographic defect fill in the absence of bleeding, the treatment is still successful. So for the reconstructive approaches, of course, we need to think about bone crafting procedures, materials along with membranes, and in this network meta-analysis performed by my dear friend and co-worker Ausra Ramanauskaite, we could identify, at least from the available data, that autogenous bone alone might not be the most favorable material because it undergoes a massive resorption in this inflammatory environment. So using materials with a low substitution rate along with a membrane might provide the best clinical outcomes, even though the evidence for this statement is still at a moderate level. So keeping this in mind, we should think about the type of the bone graft and its properties. So let's start with this first critical defect, and this is one of the most common defects that you will encounter. It's the class 1 non-contained defect. So what does it mean? We have a containment to the lingual, to the palatal side, but a non-containment to the buccal side. So for this very critical defect, we have established a procedure which is called the modified reconstructive protocol. And I would like to go into details, but before I go into the grafting, I would briefly highlight a specific flap design that is crucial, at least from my perspective, for reconstructive procedures. So it's the combination flap. So we start, of course, in a microsurgical approach with an intrasulcular incision, but as you can see, I'm trying to perform the first cut, the first marginal incision, in a way that I separate the granulation tissue from the flap. So in those defects, the class 1 non-contained and the class 3 defects that we will discuss later on, they reveal a massive granulation tissue formation, which is baked and densely connected with the flap. So again, this first incision separates the flap from the granulation tissue. So the next step is to prepare the macroperiosteal component of this combination flap. So this is one component of the combination flap, and the second will come in a couple of seconds. So to complete the macroperiosteal flap preparation, we slightly extend beyond the margin, keratinized, non-keratinized tissue, to the vestibulum. So we don't perform the deep vertical releasing cuts as we would do for the full thickness flap. So this is now to complete the separation of the granulation tissue from the flap. So this is quite critical because you need to do everything possible in order to preserve the flap and not to perforate the flap. And this can easily happen. So the removal of the granulation tissue. So we are now at the stage where we have elevated the full thickness component, and this usually goes to the level of the bottom of the defect. So to the level of the bottom of the defect, we perform the full thickness flap. And exactly here, as you can see, we perform the periosteal releasing. So the periosteal releasing incision is performed at a higher level, as opposed to the deep periosteal releasing incision that we would do for the full thickness flap. So after the releasing of the periosteum, we proceed with the second component of the flap, and this is the split thickness component. So at the end, we combine a full thickness component to the bottom of the defect with the partial thickness component towards the apical region. So here in a nice depiction from an in vitro study not yet published by, well, our dear friend and co-worker Christian Rabe from Bern, and he's now spending some time in Frankfurt in our department. So this is how the combination flap looks. So in essence, we keep part of the periosteum to support, to provide containment to the grafting procedure. So that's the basic idea of the procedure. So the next step, the decontamination of the surface, and we could discuss an entire session about the decontamination protocols that we see in the literature, but we can also make it very simple by quoting our EFP consensus. And here we have, of course, identified all the possible decontamination protocols, and all that remained was a titanium brush, because the titanium brushes are supported by evidence and they make a clinically relevant difference, and therefore titanium brushes have become quite frequently used. So the addition of chemical tools, chemical agents, or in this case EDTA, is something that you may use, but you should not expect a major difference. But this is part of our protocol, so we apply EDTA, but not to clean the surface, more to reduce the bleeding in those areas where, of course, the hyperemia causes some severe clinical problems during the surgery. So now let's proceed the step towards the grafting procedure. And I have quoted the modified reconstructive protocol. So modified in the first instance means we have used this combination flap. The second is, so again, we have no containment to the buccal side. We use a material that provides containment on its own. So this is a collagen stabilized bovine bone mineral, and as you can see, this material provides this extra stability in this non-contained area. So let's call it a sticky bone concept. So don't put particles that are loose, because the particles, they may float around, and that's the rationale for using such a stabilized material, always in combination here with native collagen membranes. And the wound closure to obtain, and this is important, a transmucosal healing, because we always go for transmucosal healing procedures. So that's the case that you have seen before we started the presentation. That was the starting point. So that's a class 1 non-contained defect, just to make it clear again. And what we did, we have used the modified reconstructive protocol, as you have just seen. So the combination flap, the sticky bone concept, the membrane transmucosal healing. And again, looking at our outcomes that we can measure as clinicians, we have obtained no bleeding, no suppuration 12 months later. And when we look at the radiograph, in this case taken 2 years later, because it sometimes takes a lot of time in order to get a defect fill, we have obtained all the criteria classifying this case as successfully treated. So I don't care about re-osseointegration because I could never measure it. So I'm happy with what we have achieved, and this is a summary of the data. So when we look at the publication where we have presented this modified protocol, and when we define the different thresholds, so these are the patients that had received the sticky bone concept with or without autogenous bone addition, and with or without a membrane. So here we have the full package. And when we look at the outcomes in terms of disease resolution, we are within the range of 70 to 80, close to 90, after a period of 1 year. So most of you have quoted for this case a reconstructive procedure, and here we go, yes, that was a good decision, so 80% of success. Next defect. So here we have a tiny little difference, and this is the class 2 component, so the supracrestal component, which comes on top. And this is what we call a class 3 defect. So a class 3 defect is a class 2 defect plus a class 1 non-contained. That means in this defect we have mainly non-contained areas, so that makes this defect so critical. The bad news is that this is one of the most frequent, the most common defects that you will encounter in your day-to-day clinical practice. So this is really advanced peri-implantitis. And that's why we had established many years ago this combination protocol. And again, to give you a brief summary on what we do, so we combine this implantoplasty procedure with a reconstructive approach. So usually, or I would say in most of the cases, we always start with a non-surgical treatment in order to reduce signs of inflammation, but we proceed with the surgical step most commonly between 1, 2, 3, or 4 weeks, so within a short period of time. So that's a class 3 defect, mainly non-contained. So what does it mean? It means that we use this combination protocol in a way that all these non-contained areas where we consider a reconstructive procedure as, I would say, not highly predictable, we use the implantoplasty and we just provide the bone graft in the contained areas. So depending on the type of the defect, you may end up in different combinations of the implantoplasty and the bone grafting procedure. And here we go, this is this case over a period of 7 years. So what you see is, of course, there is some mucosal recession, but again, no bleeding, no suppuration, and this is, again, a successful treatment outcome. So this combination therapy has been used and adopted by other authors, and they have combined this procedure with different bone graft materials, so bovine bone, biphasic calcium phosphate, allogenic bone, of course, with different follow-up periods, but there is a solid and a fundamental evidence behind this concept, and we put now this protocol into perception, and we look again at the disease resolution. Here, with this protocol, we have 7-year follow-up data, and we end up in a disease resolution of 80%. So again, 8 out of 10 patients could be successfully treated with this combination protocol. And when we just consider bleeding and suppuration without the probing depth threshold, we are even up to 90%. So some re-entries, also really rare cases, a reopening after certain periods of time. So again, we have the class 3 defect, the implantoplasty, the reconstructive procedure for the contained areas, transmucosal healing, and that's the re-entry 8 months. For the case in the middle, that's the re-entry after 7 months. And on the right-hand side, you see the case, the re-entry after a period of 6.5 years. So what these defects all have in common is one thing. Where you put the bone graft, you get a new hard tissue formation, and where you perform the implantoplasty, you get a new transmucosal area as you would have it with an abutment or with a tissue-level type of an implant. So that's the basic rationale. Another case, a re-entry, so starting point class 3 defect, and the same finding, intraosseous defect fill and the maintenance of the transmucosal area by the implantoplasty. So that's the basic rationale. So we are quite predictable in terms of obtaining or managing bleeding scores, probing depth, but we have still difficulties to maintain the aesthetic component and appearance. So that's why when you raise a flap, even with the combination flap, you ultimately end up in a mucosal recession formation within the range of about 1–1.5 millimeter. So we have investigated many efforts in time in order to understand what is happening in the peri-implant tissues after the surgical procedure, and it became apparent that we, in the first step, get a reduction in tissue volume in the most crestal, in the most marginal area of the mucosa. And in the second step, the mucosal margin goes down. So that means we always provide a volume graft in aesthetically relevant areas. So a volume graft might be a collagen matrix or a connective tissue graft, but the idea and the concept is that we place the connective tissue graft under the flap, we connect it to the flap, we provide a volume to keep the mucosal margin in place. So my clear recommendation is always use a volume graft in the aesthetic zone. So Hom-Lay, in order to switch over to your presentation, this is the downside. When you remove an implant, this is how it will look like. So you have really advanced defects, and the most critical thing is that you lose attachment at the adjacent teeth. So these are masterclass cases, much more difficult than using any of those surgical procedures that we have just discussed. So my advice and our clinical concept is when we have to remove an implant due to peri-implantitis, we always provide a simultaneous grafting of the defect at the moment when we remove the implant. So after the excochleation of the granulation tissue, we provide a bone graft, a membrane, and in this case, we can submerge the site in order to avoid a collapse of the soft tissue. And this makes the overall procedure, so the next step, much easier, starting from that level than from the level that you have seen before with this massive collapse of the soft tissues. So whatever decision you take, also keep in mind that once you have removed the implant, you place a bone graft, you start the next round. You will never ever get back to the high osseointegration rates, so implant integration rates that we are used to. So we are now going down to 70%, and in the case that you would put the third implant in the same place, you are at a level of 50%. So this is also a critical issue that should be taken into consideration. So with this and a greeting from the team in Frankfurt, I would like to thank you for your attention.
Wow. After the Frank's talk, it's very difficult to follow up. So I think the task they gave to me today was actually re-osseointegration of the failed implant site. But before I go in and talk about this topic, I have to give you my point of view about when do I save or when do I remove the implants in order to figure out can I do the re-implant or not. So what my topic will be, the first I'm going to talk about the decision tree. When do we decide to remove? And when do we decide to actually regenerate or reconstruct? Then we're going to talk about some of the case I do the regeneration, and certainly we'll talk about some of the case I remove the implant, re-augment it, and replace the implant after several years follow-up. Then we'll do a summary about what do we learn. So the first things I usually said, for me to come here to lecture, I don't have any alteration or any changing on my slides. There's no conflict of interest on my presentation, although I did receive several research grants from the university to conduct the research, and I also received the honorarium for speaking engagement as listed in the slides. So, couple things. When we look into the implant, we have to ask ourselves, should I save or should I remove? But in order to treat the disease, the number one thing is to figure out etiology. If you cannot remove etiology, no matter how good you are to regenerate, there's no chance because it's going to recurrent. Then the second thing for implant is checking implant is move or not. If implant is moving, it's difficult to regenerate. Certainly, then the third thing I look at is amount of bone loss beyond initial biological bone remodeling. What is definition? It's the soft tissue transition zone. Every implant will have to form from your crown margin down to your bone level. Should be about 3 millimeters. That's the soft tissue transition zone. That's happened to every single one of your mouths. If you look in your natural dentition, from your CEJ line goes down, you don't see bone, you see soft tissue zone to the bone level, which is about 2 to 3 millimeters. Then you're looking into the type of a bone loss. What kind of bone loss do I have? Then I'm looking into amount of keratinoids, gingiva, a mucosa, and then the thickness, which Frank mentioned that aspect during the regeneration and treatment. So if I look at this one, I will check etiology, and then I check implant mobility. For example, when you check etiology, the number one thing, which major problem today is when you do a bone level implant. You put your crown margin right into the implant fixture level. Then you know you're going to lose 3 millimeter bone right away. Then the bacteria come, you're going to have a more periimplantitis. And that's why when people talk about bone level implants, they talk about two-piece implants, which means you need to have another abutment. And that means that abutment usually is about 3 millimeter. Or you're going to use in hybrid implant or tissue level implant to occupy that zone, in particular in the anterior aesthetic area. Then you check your implant mobility here. If implant is moving, then usually we take it out. That's much easy. So we're going to talk about how do we redo the site and replant the implants. Certainly, if a crown or screw is loosening, usually it's due to one, occlusal trauma, which is an important aspect. Although there's no research, but it's important. We see more and more often. So if I see a screw loosening or crown loosening, I check the occlusion. And if I do occlusal trauma, I do the occlusal adjustment, then I put a new screw, tighten it up or new crown. Then if there's no more occlusion, then go ahead, I will just tighten and put in a new screw. Then if the prosthesis is fractured or abutment is fractured, most of us know, put in a new crown, new prosthesis or new abutment should be fine. So then the next thing you look at is I check the implant mobility and then I check the bone loss, which is 12 months. 12 months after prosthesis in place. That's where the initial biological bone remodeling will take place. Then, if I don't have anything beyond that point, we call peri-implant mucositis. And generally speaking, you can treat it with many non-surgical treatments, such as lasers, soft tissue graft, airflow, or even mechanical instrumentation. Then I look into the peri-implantitis side, which means I have the bone loss beyond biological bone remodeling. In this situation, if I have only 20 to 25% bone loss, or we call early peri-implantitis, we call the non-surgical treatment. You don't need to open it, you just need to maintain it. But if I have a more bone loss, which more than half of the implant fixture length, which is 50% of bone loss, generally speaking, there are a couple ways you have to ask yourself. For me, I like to do a submerged approach. Frank showed you all the non-submerged approach, which is regeneration. I personally believe you need to remove the prosthesis in order to get total regeneration. So in that situation, I can either do two things. If a patient say, no way to remove my prosthesis, then I'm gonna do remove the implant, or I'm gonna do an implantoplasty, because that's the way I can maintain the area much better. But if the sites, which many things people look at it, the defect, which Frank talked about, all this wonderful defect morphology, that's determine factors for you to decide. If you see the site, you cannot have a bony wall support, then you go into either implantoplasty or remove the implants. So that's where you see it. Now, if you have the infraosseous defect, which is the one which we call most reconstructive regenerate defect, then we go with the regeneration protocol I published called EPDDS. So if you know that, then generally speaking, there are one way which we have to think about regeneration is peri-implantitis, the bone loss, which is more than 20 to 25%, but less than 50%. That's the area you have to ask yourself, should I regenerate or should I remove the implant? So in that situation, many of us think about if I have a supraosseous defect, I do the APF with implantoplasty. If I have the defect, which is infraosseous defect, then I ask myself, do I have a keratinoid mucosa? If I do, then I do so-called the autogenous or soft tissue substitute, such as collagen matrix. But if I don't have a keratinoid mucosa, then I only go with autogenous, which is the key. Many of us know that, which is more predictable. So with that, we're going to talk about very briefly EPDDS. My job is not going through this today, but if you're looking into the granulation protocol, in order to treat the peri-implantitis, the number one things, you got to remove infective or contaminate surface, be clean. So we want to remove the granulation tissue with curette. Any supraosseous defect, you can talk about implantoplasty or even titanium brush. Then infraosseous defect, I like to go through the regimen, such as I use in the titanium brush and lasers and airflow. I use in the erythritol powder, then saline irrigation before I do the GBR. And there are other material you can use them for cleaning, still under the research called electrolytic cleaning, so people talk about it. Now, if I look at it here, just very briefly introduce about the instrumentation I use, that's implantoplasty burr, we use in the contra angle with a handpiece with the RPM. The titanium brush, most of you probably don't know, I actually developed this tool, and it's actually my idea, and which those of you use it, you probably don't know, that's the one I actually developed. So it's very interesting, people starting to love this titanium brush. Then we do lasers or air abrasive. So that's the regimen I use. So if I go through that very quick, the defect before and after. So if I take one simple case to illustrate this, that's a peri-implantitis, more than 50% of bone loss. I remove the covers, the abutment and crown or prosthesis. Then I will go ahead, figure out what type of a defect. You can see circumferential defect in each one. So I debride, then I do an implantoplasty on supraosseous defect, the same things I mentioned on my disinfection protocol. Then I go in using my laser airflow. Then I put my bone graft with the autogenous, mixed with allograft, and sometimes I also mix with xenograft. And usually I want at least 50% of autogenous bone graft, and I put the PRF as a sticky bone. So in that sense, I end up using PTFE membrane. I punch a couple holes and put my PRF membrane on top, and I close the flap with tension-free release. And you can see the 2 weeks follow-up, very nice. And what is exciting is after 8 months, when you re-enter the area, you see the bone formation. If you don't see a wonderful result, usually we recommend that you do a second graft. When you do a second graft, you can do actually the allograft or sometimes even xenograft with collagen membrane. That will help your graft maturation. So then you correct your prosthesis, because part of the reason is also prosthesis cause some of the leading problems for peri-implantitis. And the joke I usually mention is not the peri-implantitis, it's a peri-implant prosthodontitis, because pros is a part of the equation when we look at. So in a sense, the one you see the before and after, it's right here, and before and after. That's after 8 months, and that's a CBCT comparison, before and after. So it's a very clearly show what we can do in this approach. Now, very quickly, I have just show you 1 minute on the re-entry, also and the surgery. So you can see this is actually well documented. So we open the area at 8 months, and you can see here when we remove the screw, fixation screw, we can see the bone formation. The reason we punch the hole on PTFE membrane is because we want the blood supply. We want to vitalize the graft material. So you can see once you take the membrane out, the graft is no longer white, but it's a red with the life, which called blood supply. So you can see very beautifully on the regenerate bone formation. And this is basically the slide I show you already. How do you do all these procedures on this case? So with that, we published a paper and talk about submerged heating approach, so-called EPDDS. And as you can clearly see before, after, we got many cases to show you we pretty much can regenerate back to the original level. By using this protocol, by submerging, we can get at least 3.5 millimeter of a bone formation without problem and predictable. So people then ask me, what kind of re-osseointegration you got when you regenerate the peri-implantitis? As Frank mentioned, and he got about less and less each time. But when we look into the peri-implantitis experiment by Mariano Sands group, what he found out is he creates the defect in the big old dogs, and then he using the recombinant BMP2 and bioas collagen to repair together with the collagen membranes. And in this particular study, what did they find it out? In histology, compared to the saline group, which without a recombinant BMP2, what do we have? It's a very interesting. We only got 40% of a re-osseointegration. With or without using recombinant BMP, does not help. But maybe the dosage is a little bit different. So I think Urban actually mentioned that using the low dosage, the recombinant BMP, which is the 0.5 milligram, will be better for regeneration. So the question is that enough for maintain the implant? So we learned the re-osseointegration is partial re-osseointegration. So if I look at it, maybe I should have taken the implant out, put a new one, and see what kind of re-osseointegration I have. So for me, when do I remove the implant? If I cannot control or remove etiology, because wrong implant position or prosthesis I cannot clean, or it's not ideal regenerative defect, or patient didn't want to remove the prosthesis for me to do a submerged approach, or I have more than 50% of bone loss. And a lot of times, if we are single implant, I like to take it out versus multiple implant, because single implant is much easier to take it out and redo it. So, and also the younger patient, because they have a more lifespan to work, instead of kind of a manage the peri-implantitis, sometimes take it out, put a new one in a better position, better prosthesis. It's probably better for the patient. So with that, people starting to ask about when do I remove the implant? I remember I came here almost 20 years ago in a PISA consensus. We talk about more than 50% of the bone loss. It's time for remove the implant. That happened 20 years ago in Italy in Pisa. So we decide that's the things we do. And we also publish many papers talk about when I have more than 50% of bone loss, it's actually higher risk to lose compared to I have a minimal amount of bone loss. For example, 25% of bone loss, I have 20 times more likely I'm going to lose that when I have a more than 50% of a bone loss. So 50% is the threshold for me sometimes when I decide to remove or not. So for example, this patient just had the implant done and he got a defect all the way done, remodel done. And patient was upset and he came to see me and saying, what do I do? Especially if the implant is not done by me and they come to see me, what I always do is take the implant out because I'm not going to inherit the problem. So I will take it out, and it's easy using the implant removal kit with an inner screw, 45 to 55 Newton centimeter, and then using the trifine, which is a clockwise, and remove the implant with this. Then I do my GBR and let it heal, and so it's much easier for me. So the question then becomes, I have a better bone now. What do I do? So I go back and I open the area and put in the new implant and in a better position and much wider diameter. So in this situation, I did it. And you can see, for me, it's a tissue level implant with adequate soft tissue around it. And I can restore that implant without problem. Although that restoration is not what I like. It's a little bit bulky, but you can see my implant was in the center position, very nice. So again, you need to have a team understand the prosthesis to get you the result you need. For us as a surgeon, usually difficult. We are relying on prosthodontics to help. So, for example, the implant failed. For me, I usually would take it out and put the bone augmentation and come back and put a new implant in a better position and restore it in a better form. So many of the things people start to say, when you do a failed implant and you do a re-implantation, what happened? So in this particular study in 2022, they found out the average implant survival rate, it's about almost 96 or 97%. But it's about 3.7% of an implant fail. Out of this 3.7% failed implant, out of 69 implants in 61 patients will re-implant, which is redo again. And at this time, out of a 69 failed implant, they did it, and they failed 11.6%. So that means the first time it fails, 3.7, second time, 11.6. Then 3 out of this failed patient willing to come back and redo it. At this time, they got 100% success rate. So there's no fail. So again, there's no clear rule, but you still starting to look at it here. You have first time fail, 3.7, re-fail, 11.6, then you got 100% success rate. And what is important? It's not an implant. It's the age of your reimplantation. And it's also the smoking. Patient who smokes has more problem. Also, patient is taking an anti-thrombic agent. So that's the things you have to know. Anticoagulant, this type of medication, may actually has a negative association toward to the osseointegration in the second time. So previous failed, that does not mean it's going to affect your success of your next implants. So we learned that very much, very quick. So this is the failed 2 implants, as you can see here. So what did I do? When the implants fail, I remove all the infected granulation tissue. I clean up all the granular particle of your bone graft, and I redo the sinus elevation, and I place the implant in the ideal position, and then I actually end up doing the sinus lift with the long abutment. So people say, do I need a vertical bone augmentation? I didn't. I actually using the long abutment with the APF. You can see the long abutment. And I consider that's the supracrestal tissue zone. So I build up that, and with the bispring to protect the occlusion. What you see is when the patient follow up 4 years, no problem whatsoever, no bone loss. How about 10 years, no bone loss? How about 22 years? Again, no bone loss. So re-implantation, re-osseointegration, it does happen on the failed implant side if you treat it well. Then people then talk about if you have a previous failed implant versus pristine implants, any difference? But basically no difference in the pristine implant versus replaced implant side. The only difference is when you do a re-implant side, you need a more bone augmentation. That's all. We know you have to because peri-implantitis causes bone loss, and you're going to do some bone augmentation for that purpose. So that's easy. The second question is, for example, this is a patient I treat. They have a failed implants due to osteomyelitis, and I clean up the infection, and I put the implant on this osteomyelitis site with the implant and free gingival graft, build out the zone of a keratinoid mucosa, and I follow up this patient. Again, we don't understand the procedure, why do they need to put it that long, but that's part of the problem. But we follow up this patient with a bispring, 4 years, 10 years, and we even follow up to 15 years and 18 years until a patient passes away. She still have all the implants. So to me, that's re-implantation. That's re-osseointegration. The last one we're going to talk about is if I have an 004 or 06 failed, which is very popular problem today, you're going to go back and redo the bone augmentation and replace the implant. Does that matter? So in this particular study by Unclean, it basically showed it didn't matter. Regraft and re-implantation on the failed implant side is a safe and predictable treatment procedures. So the same things, I'm going to bring one concept. If that's the case, why don't we take the implant out, put a new implant in, and do a GBR at the same time? That's what I call rescue implants. When I have a failed implant, instead of doing a bone augmentation in the stage approach, I can take that implant out and put a new implant in the same site and do a GBR. And with that, I can save patient time, and I know I can get a re-osseointegration without problems. So that's a new concept, a new approach. Instead of trying to save the implant, sometimes creates even more challenging for the patient. So with that, I'm going to conclude that re-implantation is an effective clinical procedure. However, I got 2 questions for you to answer. What percentage of re-osseointegration is typically achieved at the sites of a previous failed implant? Do different biomaterials, such as a bone graft or membrane you use, or the technique you used in reconstructive influence the outcome, such as the degree of osseointegration, the extent of marginal bone loss, and the instance of the peri-implantitis or peri-implant mucositis? I think that's the question remains to be answered, and that's why you are all here trying to figure out that. With that, I'd like to thank you and wish you all the best. Thank you.
Stay seated. So, thank you for the outstanding lectures, and we have some questions from the audience, and we also, I think we have some questions. You're the specialist, so you're here to answer our questions. We have a few questions from participants asking about the implant, the titanium particles when you do the implantoplasty. Do you have tips on how to prevent or minimize the contamination with of the tissue, of the surrounding tissue? And do you see any problems with titanium particles?
So the way I do implantoplasty to avoid the titanium particle is before I open the flap, if I can do an implantoplasty before open the flap, I will do it. Then you can open the flap, but before you remove the granulation tissue, you can also do an implantoplasty. Then you remove the granulation tissue. Now, if you choose to remove the granulation tissue, which you can, then after you remove the granulation tissue, I like to put both we call it bone wax, which the material you can use the bone wax, you put it infraosseous defect, then you do the implantoplasty, then using the airflow. That's what I do to minimize the titanium particle.
Yeah, same for me. Keeping the granulation tissue makes a lot of sense. So that's a similar approach.
Yeah, and I noticed when you showed your cases, like you had submerged healing and you had non-submerged healing. Is there a situation where you would say it should always be non-submerged or submerged? And are there data which one has a better success rate?
No, the direct comparison is lacking. A matter of fact, 85 to 90% of the literature reports on transmucosal healing, and I think the main obstacle is that, I think in the aesthetic zone, removing a fixed crown, a cemented crown, an abutment, it's not that easy. And the second is, of course, what is the provisional restoration? Not that easy. And the third is the exposure rate, and this is what we also see. Inflamed tissue, it's hard to keep it closed. So the exposure rate is higher than we have exposure rates when we do normal grafting procedures. So these are three components that add up and lead, at least for me, to the conclusion going for transmucosal healing.
We did a study actually using the non-submerged healing and also published. And we got only half of the result that we got on the submerged healing. And the challenge certainly is the transition procedures during this period of time. So I think you can try to do the implant on the palate with the prosthesis, or you can do a narrow diameter implant as the transition prosthesis to help out. But again, my belief is prosthetic usually play a role in the initiation or the peri-implantitis, so I have to correct it. So I always tell the patient, I'm going to redo the prosthesis, and then I can regenerate. So the patient has to decide.
Yeah, so thank you, both of you, for an amazing lecture. I have a question to Frank. You showed amazing regeneration of these severe defects. So for you personally, what is the benchmark when you say, no, here I have to remove? Or are you always aiming in regenerating, see where we end up, and then, or do you have like a decision, where are really the limits? Or so you have no limits?
Let me put one really important component into this game, and this is the patient, right? So when you ask the clinician, we can talk about the 30-50% thresholds. When you ask the patient, he doesn't care. So he has an implant in the aesthetic zone, and he, of course, has just one opinion: keep the implant. So keeping that in mind makes it very difficult, unless you ignore the patient, to come to such a conclusion. So 99% of the patients that are referred to our clinic, they have just one wish: keeping the implant. So that makes it a little bit more tricky. So personally, I do not define a threshold. unless it's 1 millimeter, yeah? But to that point, a strategically important implant, I don't see any reason not to keep it. And even if we do the bone graft, the implant gets loose, we still have developed the implant site for the next round. So the patient benefits from a reconstructive procedure anyhow.
Mm-hmm. So your goal is always to regain and to keep the implant whenever possible.
The more you come to the aesthetic zone, of course, the more likely is this decision.
Yeah. What is your opinion on that? Because I have seen in the last cases where you do the rescue implant concept. So where is the threshold for you there?
If it's a young patient, I usually like to give them a fresh one instead of trying to manage it. I deal with a lot of peri-implantitis treatment. I think it's a very challenge. It's very demanding. And if you can figure out the least traumatic and the easy and predictable way, and that's what patient wants also. So you can, although I didn't talk about it, if you do a rescue implant, can you do an immediate professionalization? That would be the huge jump. But again, you go back to Frank's concept on anterior area. If a patient want to keep that implant, and most likely, I probably go with Giovanni Zucchetti's more concept approach on the soft tissue manipulation, because the most likely in anterior was the position issues. When the position is outside, there's no way you can go bone. So the best way is always soft tissue, and that's the way you're going to manage it if you want to keep it.
So this is a key factor, also the position of the implant. If you're outside of the envelope, then it's probably really tricky. And what you talked about, 50% of bone loss, this is an indication for you to do an explantation. And the lingual bone, I saw in your cases, Frank, you still had lingual bone.
Yeah.
So I think, isn't this an important factor also on how to decide what to do?
Of course, when we place implants, whatever you have as a ridge width, when it becomes narrow, we all know that we always have to avoid to get adhesions to the lingual or to the palatal side, because this is much harder to regenerate than the buccal side. And the same applies to peri-implantitis. So once the lingual bone, the palatal bone is missing, so you have a through and through defect. I would rather define this, in fact, as an implant that is almost hopeless, so really challenging to keep.
Okay, so there is a point when you do an explantation.
Yes, at least that point.
Hom-Lay, there is a question regarding the implant design. When you do the re-implantation, what kind of implant design would you use? Would you use a polished neck? Because I saw in your presentation you also use kind of bone level implants because they favor probably regeneration. What would be your choice?
Good question. Usually I said, if I do a bone level is a two-piece implant, means I need to have a Barman. And personally, I like to do a hybrid implant or a tissue level implant, especially in the fail site, because that will give me the backup room about 2 to 3 millimeter. Then the prosthesis will be put on top. So it's much easier because I can get a soft tissue instead of bone up. So if I do a re-implant site, I like to go with more tissue level or hybrid type of implant. That's, to me, that's probably a better way.
Yep. Yep. And we also had a question about antibiotics.
Yeah.
You had it on your slide saying that you use this. I think you don't use it. I think in Germany we're really reluctant with it. So what's the position on this?
Well, we have to differentiate. So the one is the adjunctive use of systemic antibiotics to support the treatment outcome, and the EFP consensus is quite clear on that point. There is no evidence and it's not recommended. The second is, however, the prophylactic administration, a one-shot, single application, and in that regard, the literature is non-existent. So we have just completed a retrospective analysis, including almost 200 patients, and here it became quite clear that the one-shot antibiotic prophylaxis, along with our transmucosal healing, definitely makes a difference. So that means I would definitely recommend, on my personal opinion, to use a one-shot, but for the sake of having a prophylaxis regimen.
And Hom-Lay?
You know, for the U.S. it's a little bit different. I think legally, because when you get in trouble with any legal case, the lawyer first question, do you prescribe antibiotics or not? And if you don't, you have to provide all the evidence, which Frank mentioned there's none. So you have to justify it. But if you prescribe it, then you take that question out. Also, you know, during the peri-implantitis, you got an infection already going on. And you also put in a lot of the biomaterials in there. And I like to cover myself a little bit more, so I like to prescribe short period, 5 to 7 days of antibiotics if I can.
Okay, but I think the EAO is working on this, right? And the AO working on the question about the antibiotics and the evidence that we need to maybe get.
Yeah, hopefully.
Another question from the audience, the role of biologics in your treatments. So you showed the PRF. What do you think about other biologics in your treatment?
Urban and I, Dr. Ishwan Urban and I just published a paper, which is just accepted. We're using a recombinant BMP2 low dosage to treat the peri-implantitis. So I believe biological has its role in regeneration of this big defect. Now, do I use in PRF? I like using the PRF to promote my soft tissue healing. But the evidence, it does not support the PRF to promote a bone formation. But I like using as the other way is promote my healing. So indirectly, I can get bone, that's all.
And Frank, I noticed that you use some autologous bone chips.
Yes.
And put it on the implant before you place the biomaterial. Is that your approach?
That's part of the modified protocol, and we have seen that without autogenous, it's at a lower level, so we benefit from it. But whatever we discuss, you always have to keep in mind the cost. So when it sums up tremendously, so non-surgical treatment, bone grafting, membrane, volume graft, biologics, so at the end it's exploding. And this is also one point that needs to be addressed. Focus on the components that really make a difference.
So autologous bone is cheap, it's right
it's
there.
It's cheap and it's simple.
And it's a biologic.
It's biologic, that's why we are using it, but not alone. And that makes, again, to me and according to the literature, sense. The resorption in an inflamed environment is quite extensive.
Yeah.
Is there another question? Many, probably.
Many more. I need a second to... yes, the question is just what is the best bone graft, but I think we don't have the clear answer yet. Would you comment on those?
Yeah, I was referring to the literature. It's a matter of fact. Bovine bone minerals, low substitution rate, were most commonly used. At least 70% of the literature uses this type of graft material.
I think in the US it's a little bit different.
It's
right?
a little bit different. Yeah. I think the US is more allogenic, so that's because they want to replace. And the way I always said, when you treat the big graft or peri-implantitis defect, I like using autogenous bone, at least 50%. Then the rest 50% you can mix with allograft or xenograft. To me, I think it's fine. But I want at least 50% of them are autogenous because I need that cells.
Yeah, it's the same for us. But the literature is not different in the US. Hopefully not.
No.
So we talked about the bone, but I think also the soft tissue is really important when you look at it. You mentioned thickening of the soft tissue. Do we have can we substitute autologous tissue grafts? And you said if there is no attached gingiva, keratinized mucosa, as you said, then you have to use autologous grafting. What is the? I mean, that's the second most important, or maybe the first main important success factor for a long-term implant stability, the soft tissue?
This is something that we should not discuss in 2024. Keratinized tissue is one of the major local risk factors. And when we extrapolate these findings that we have for the prevention, we of course establish keratinized tissue before we go for the surgical steps. And for the submerged healing, might be different because you close, you lose again keratinization. So here it might, but for the transmucosal healing, it's crucial.
So if you have no keratinized tissue and you want to do the transmucosal healing, how would you proceed?
Non-surgical treatment to get a reduction in bleeding, soft tissue graft. 3 months later, we go for the surgery.
I probably agree, or I do the autogenous, either FGG, free gingival graft, or the connective tissue graft, then the Epsilite. So.
Now, if you have like a thin phenotype, would you always thicken it?
I like to see at least 2 millimeters, so I thicken it. I do. I like using the rule of the 2, because 2 millimeter keratinized mucosa, 2 millimeter of the thickness, and 2 millimeter of buccal bone. At least I use it as a 3 millimeter vertical tissue height.
Yeah. So the evidence is not there to support a thicker mucosa for the prevention. So we just do it for the sake of keeping aesthetics in the aesthetic zone. That's why we just limit it to 5 to 5 in the maxilla.
Okay.
So I think we covered what we need for the bone, what we need for the soft tissues. We covered the biologics. So I think it has to be, it was a wonderful session. Thank you so much for the speakers. Would you have to have the final word, Kajia?
The final word? No,
Yes.
We all have the final word. We thank you for being here. I hope we answered some of your questions. I enjoyed having you two, or moderating you two with you. I hope you have other very good sessions, and it was nice having you here. Okay.
Thank you so much.
Thank you.